Thank you, Dr. Akbik, for joining us today on the Pain Pod. Dr. Akbik, why don't you share a little bit about yourself with our listeners? Tell us how you got to interventional pain medicine.
Thank you very much, Dakota, for hosting me in your podcast. And if you look at pain, pain is relatively a new specialty. It started in the late 90s where people start acknowledging pain medicine as a specialty. And that's where actually it's just the American Anesthesia Board created a board for pain medicine.
Oh,
And that's
wow.
when it becomes more and more known of there is a pain medicine board and there's a specialty called pain medicine. That's what intrigued me. It's a new specialty. And to tell you the honest truth, the whole idea was about options. In the past, when a patient come and have back pain, they used to come and either see the surgeon or there's only one thing to do is cortisone injection and that's it. And the
Mm.
patient has to live and suffer. Then the opioid epidemic came in just because of the overuse of opioid. And that was now curtailed. So basically, really, patients back to square one where there's not many options. But in the last 5 to 10 years, a lot of new development has been established in the world of pain medicine. When I started my residency and fellowship, I started at the Brigham and Women and Harvard Medical School. And it was one of the icons of pain medicine where really everything started. And then I went and worked at the VA. And the VA has enlightened me and brought a new perspective of pain to me. And this is what sparked my passion actually to the specialty is helping the veterans cope with their pain and be able to get back to their civilian life. Looking at back at that time and looking at now, it's very promising to see more and more options for our patients where they can buy time, if you want to say that, or we can prolong the need for having surgery. Many of them, what I see now, is what we call lumbar stenosis. Lumbar stenosis basically is the disease of the spine where it's become tight around the nerve. And it's harder and harder for people to walk for distance or to stand up for a period of time. And they find themselves either sitting all the time, laying down all the time, or really not doing much just because of the pain that they feel down their lower back and their legs. The classic treatment for that, if they go to a neurosurgeon and the neurosurgeon will tell, well, you need a laminectomy or laminotomy, and they go in and they have the surgery. But remember, usually the whole spine is stenotic, the whole lumbar spine. So you have one level, a few years later you have the other level, a few years later you have the other level, and then it's constant and continuous surgeries. And the patient never really recover. How can we help them? We started with the epidural steroid injection or transforaminal injections. This is what the normal layman term knows that I get a cortisone injection in my back. It helps me for a few weeks, few months, but then what? Then I'm
Mm-hmm.
back to square one. Well, I don't want to do surgery. Now, there is criteria for surgery. Now, if the patient has severe weakness, then the mechanical stenosis is too much and probably they should consider surgery before anything else. But what if they don't have the severe symptoms, but the symptoms are enough to really alter their activity of daily living and decrease the quality of life? What do we have to offer them beside the injections? Most of them, they don't want to take pain medication. Most of them are a little bit older in age and they don't want to go under anesthesia. Most of them, they have active life and they want to restore their active life without the need of surgery. So the science has improved. In the last 10 years, we have developed what we call in the pain medicine, what we call minimally invasive spine procedures. And the minimally invasive spine procedure is a little bit different than minimally invasive surgery, that the one is done by the neurosurgeon. The minimally invasive spine procedures is where we can go in the spine and try to free the nerve or clean up around the nerve from the elements that causing the nerve to be tight or be touched and relieve the pain. And I'll show you a few things here.
Oh, neat.
So if this is our spine, correct? Now, this is where everybody talk about the disc. That's the big disc that people say, I have a disc herniated, I have degeneration in my disc, I have blackened disc. That's what the disc is, what we mean. But we have other elements of the spine. This is the nerve that goes down the leg. And you can see clearly that there's a box, and that nerve comes out of the box and go down the leg. When we get older, we get mature more in life, we have something called the small discs, and those are the small discs, and that's where the arthritis build. Many patients says, I have arthritis in my back. Well, that's where the arthritis build in. But the arthritis can build outside or can build inside that box. And this is a box. And the box is restricted in volume, and the nerve is in there. So when you have extra bone in there, that's not touching. Also, what we have inside is a ligament. The ligament hold those vertebrae together.
Okay.
And that ligament, with also maturity in life, get thickened and also contribute more to squeezing that nerve. So basically, what do? We go in with a needle to that area above the nerve, and we start taking some of the ligaments out and some of the bone out, and that would free the nerve. And if you read the MRIs or the CT scan, it tells you 2 or 3 or 4 or 5 millimeter stenosis. So it is enough for us to take few millimeters out, and that would free the nerve. And what happened is that would allow the pain going down the leg to stop or be minimized because there's not much pressure on the nerve. The nice thing about it, though, is that the patient feel the relief almost instantaneously. So we finish the surgery. You don't have to be intubated. You don't have to be, we put you on a twilight sleep, like as if when you go to colonoscopy.
Okay.
Okay. So you go down, clean your back. We go in, you sleep. You don't feel anything. We go in, we clean the nerve. You wake up, and it's amazing. You'll find the need that you really don't need to use your cane or your walker. It is interesting, though, to understand how do you diagnose the lumbar stenosis. Many don't recognize that they have stenosis. Actually, it's more recognized by their family member. They find their loved one leaning more and more on the counter when they're cooking. Or they're bringing a chair in the kitchen and they keep frequently sitting. Or they cannot really finish all their dishes at the same time. What they do, they finish a little bit, they go sit, they come back again.
That makes sense.
They cannot finish the cooking. They go back, they sit, and then they come back cooking. Let's say they want to go and walk around the block. They cannot walk around the block. So what they do, they use their cane. And you find them more and more leaning over the cane. Then the cane is not becoming enough. So they use a walker. And then when they go to do their grocery shopping, they found themselves fighting over the cart. Why? Because they lean over it, it's going. But why? Because if you notice that this box, if you lean forward, that's open the spine. When it opened the spine, that relieve the nerve and make this box bigger.
Okay.
And that's why more and more they lean forward.
So this procedure that you're talking about, the minimally invasive lumbar decompression, that's just essentially kind of releasing that nerve because you've got all this extra arthritic stuff in there.
That is correct. So if this was not enough, how can we keep the spine forward like this?
Oh, yeah.
So many of us, our generation, used to change our own tire. We didn't have a AAA to call. So basically, you go in, you take the spare tire from the trunk, and you go in, and with the jack, you lift the car up. And that jack becomes like first straight, and then starts open up. Exactly the same thing. There's a new device that we put it in and go straight in, and then we, exactly like here, we use the jack to lift it up, and that causes the spine to stay
Oh, very cool.
open. And this is, again, you don't have to put the patient to sleep.
Oh,
You just give them twilight. You make a small incision between here, very small incision. You open up, you put it in, you opened it, and now they have more of a permanent flexion of the spine, so they don't have to depend on the walker to walk, or the cane to walk, or the cart to hang on, and they can walk for longer distance.
so with this, just for our listeners, this little device, how big would you say this
That's the
implant
actual
is?
size.
Is it an inch big? I mean,
This is what it's
this,
about knuckle.
okay,
This is how it is. It's almost like just a knuckle. That's it. And this, remember, this will be, the wings will be straight. So basically, this is the incision that we have to make. This is how
just a
small the
couple of
incision
millimeters.
is. Yes, it's maybe half an inch
Half
at the
an inch.
most.
Wow. And so your patients, when they either get the mild or the Vertiflex procedure, are they, walking out that same day? What's their recovery period like?
Well, definitely they go in and they go out, and they, once they finish the surgery, they go to recovery, and after recovery they leave the hospital with their friends walking, and the recovery is basically the discomfort that they feel from the very small incision. They can go back to their activity as tolerated, same day, next day.
Wow.
There's no restriction actually in their activity at all. So if they have a planned vacation, or they have a planned events, they can continue as planned, as long as we just make sure that we see them a few days after the surgery, make sure the wound is clean and healed, then they can do whatever they want. There's really not many restrictions.
Wow. So you've got two options for spinal stenosis. You've got the mild that has no implants. It's just kind of digging some stuff out for us layman people. And then you've got an implant, a very tiny mechanical device that will open up. And that grocery cart example was really great. But so there's a lot of options, right? It sounds like you can do implants, you can do non-implant surgeries. Um, what's your progression? Like when you have a patient come in, how do you decide between the mild or an implant?
It depends really on their MRI and how tight it is. Most of the time, we really start with the mild, because mild has no implant. We
Oh,
go
okay.
in, and that's a step after we do this cortisone shot, because we need to make sure that the level of the stenosis correspond with their discomfort, correspond where we're going to do the surgery. And we
Okay.
can do more than one level at a time. That's for a fact. And we can do both sides at the same
Oh,
time
wow.
as well. So we don't are restricted with one or two levels. We can do more than two or three levels, and we can do more than one side, right and left, all at the same time.
Wow.
Let's say month later they start having pain again. We can repeat the cortisone injection, see where exactly the pain is. Usually this type of surgery lasts about a year to 2 years. But let's say down the road we figure out where the most stenosis is, and then we can either repeat the procedure, or we can go ahead with the device. And that's, remember, I mean, we're talking years of their life. We were able to postpone their surgery, that they don't need to have the surgery. So how many people would rather do those type of procedure rather than have a quiet surgery? But again,
Right.
this is not alternative. Because many patients, they say, okay, if I have this one, can I have surgery? Of course. This will not stop you from having the surgery. You can still have the surgery that you need when you need it, and if you need it down the road. This is just an alternative to, and if we find out that give you enough relief, improved your quality of life enough, increased your activity enough, you may not need surgery at all.
Wow. That's huge. These minimally invasive procedures, provide options, just like you were saying. One of the reasons you got into interventional pain medicine is because of all the options that exist to patients where they don't have to incur that huge medical bill for a hospital stay for a big back surgery. Or maybe the patient who's like, I'm scared of a big back surgery. I don't have time to be down for that long. But what you're saying is it's just an option. You can still do back surgery down the road if it's indicated. But right now, we have some really easy, innovative technology that we can offer you right now.
You're absolutely correct. I started doing this procedure over 5 years ago, 6 years ago, and um, I would say I would have more about 80% success rate.
Wow.
Unfortunately, not all pain physicians do it yet. Only the advanced trained interventional pain physician do it, and I was lucky to be one of them. But we're hoping that more and more physicians will be able to provide it. But throughout the years, I was one of the very early adopters. I think I was one of the first one or two physicians in the US to start doing the procedure. So I have done so many of them, and definitely I can tell you that the outcome are very, very promising and gives a
Excellent.
very good option to patients not to proceed or at least try options other than surgery or medications.
And so, if I was a patient and I'm weighing the options between a minimally invasive procedure or spine surgery, what's the relationship that you have with spine surgeons and the neurosurgeons collaborating on a patient's case like that?
Most of the time, the patient will go see the neurosurgeon, and the neurosurgeon say a couple things. You're too old for surgery, you're too sick for surgery, or you're not really yet eligible for surgery. Those are the patient that most likely will be able to help. If you cannot tolerate surgery because it's big surgery, you need anesthesia. Here, it's a small surgery and you don't need anesthesia. It's a procedure. The second of all, if you're too old, that's fine. We still can tolerate a little bit of sedation and we can do it. And that would buy time. Being old doesn't mean you have to be sitting in a chair and not able to do anything. Absolutely. You still can be active. You still can go out, walk, attend your grandkids' activities. You can walk your dog and you can be outside walking in the neighborhood. So you still can do that by offering this alternative. And the third one, you're too early, that's fine. We'll give you this. Maybe that will buy you more time and maybe you will never need the surgery.
Excellent. Well, thank you so much for joining us today, Dr. Akbik. This was incredible to learn about some of the options for spinal stenosis, that low back pain, and I hope that patients will visit us at ohiopainsolutions.com and find their way to you.
Thank you very much, and hopefully we'll be hosted back, and at that time we can talk about a new treatment for COVID. We can talk about new treatment for PTSD. So there's a lot of new treatments that we can offer as interventional pain physician to our patients.
Well, look out for episode 2 for Dr. Akbik listeners. That'll be soon to come.
Thank you.
All right. Thanks, Dr.
Thank you,
Akbik.
Dakota. Thank you.